So we good
Sir,
to
good evening.
sir, we good to go.
Okay. So you're giving a count of three.
Okay. 3, 2, 1.
Good evening, ladies and gentlemen. We are back again with yet another interesting and exciting episode of No Thrombosis Workshop series in acute ischemic stroke, where we discuss rare and interesting cases of thrombolysis in stroke. I'm Manandar Singh Rathore from the Emcure marketing team. And on behalf of Emcure Pharmaceuticals, I take this opportunity to welcome you all for this event today. We at Emcure are highly privileged to have some of the best experts in the field of neurology guiding us and supporting us for this educational initiative. Without much ado, I will take this opportunity to introduce the expert panel of doctors that we have on board for today's program. Sir needs no introduction at all. Dr. UK Mishra, who is Director Neurosciences and Head of Neurology at Apollo Medics Super Specialty Hospital, Lucknow. Sir founded the Department of Neurology at SGPGI in 1987. Sir is also a consultant at Vivekananda Polyclinic and Institute of Medical Sciences. Sir has been the Director, Executive Registrar, and Dean and in charge of research at SGPGI. Sir has trained in clinical neurophysiology in Italy, Sweden, USA as a WHO fellow. Sir has made original contributions in the field of stroke, epilepsy, CNS infections, GBS, and neurotoxicology and others. Sir has over 462 articles published in various reputed national and international journals. Welcome on board for the event, sir. Welcome, Dr. Jayanta Roy. Sir is a director, stroke program and senior consultant, Department of Neurology, Institute of Neurosciences at Kolkata. Sir is a certified neurosonologist accredited by American Society of Neuroimaging in 2005. Sir is a recipient of the 2005 American Society of Neuroimaging William M. McKinney Award for the best manuscript based on clinical research in neurosonology. Sir has over 35 publications in various reputed national and international journals. Sir is editor of various neurology books like the Clinician's Handbook in the Management of Stroke and a Clinician's Approach to Neurological Disorders. Sir has been a guest faculty at many prestigious national and international neurological meetings and conferences. We also have our guest moderator for the evening today, Dr. Sanjay Kumar Saxena. Welcome to the event, sir. Sir is senior consultant, principal director, and head of neurology at the Institute of Neurosciences, Max Hospitals. Sir is leading acute stroke management team in a highly busy center with average 15 to 20 thrombolysis per month with internationally comparable clinical outcomes like a highly impressive door-to-needle time of 20 to 30 minutes for IV thrombolysis. Sir has undertaken few drug trials as well. Sir has attended multiple courses in neurological disorders, attended multiple national and international conferences, and published multiple papers in several national and international journals. Sir has been conducting various CMEs and workshops on various neurological disorders. Our first speaker for the day is Dr. Rajeshwar. Sir is Associate Professor, Department of Neurology, Kishan Medical College and Hospital, Ludhiana. Sir has made poster presentation at the Joint European Stroke Organization and World Stroke Organization Conference 2020. Sir has also made an oral presentation at the 4th European Stroke Organization Conference 2018 at Gothenburg, Sweden. Sir has been awarded by the Indian Academy of Neurology Travel Fellowship Grant in 2018. Sir has received the first prize at the ChristMed Annual Research and Education Symposium 2018. Sir has received the Award of Honor from the Department of Health and Family Welfare, Punjab, for a mega medical checkup camp, Mansa, in November 2012. Sir has conducted several CMEs and workshops and attended several national and international conferences in neurology. Welcome for the program today, sir. And the second speaker for the evening is Dr. Satyananda. Sir is consultant, Department of Neurology at BL Kapoor Super Specialty Hospital in New Delhi. As far as Sir's research experience is concerned, Sir has more than 10 publications in journals of international repute. There are a couple of articles awaiting publication as well. Sir has attended several national and international conferences, workshops, and made several paper presentations as well. Sir has been awarded bursary for attending 23rd WCN or the World Congress of Neurology under the aegis of World Federation of Neurology at Kyoto, Japan. Sir has also been awarded bursary for attending 24th WCN or the World Congress of Neurology under the aegis of World Federation of Neurology, Dubai, UAE in 2019. With this, I hand it over to our course director, Dr. UK Mishra, and the moderators for the evening to share their thoughts and overview of the program and take it up for the two presentations for the day. Over to you, sir.
Thank you. Thank you. Good evening. Good evening, ladies and gentlemen. Am I audible?
Yes, sir, you're audible.
So I think, it has been an interruption in our very regular case discussions, which we were enjoying. But because of some national conferences and commitments, it had to be interrupted. Then there was a question whether to, do it on the next Saturday or Sunday or interrupt it. We debated, and probably it was thought that maybe we interrupt it for a month and then reassemble, because if you do something extremely regularly, then it becomes usual and becomes you are also able to check that what is the need of this type of conference. So I'm very happy that we come back after some sort of a vacation. It was a chance because of conferences. And but I felt like going back and listening to the very interesting presentations, and you learn with every presentation. So I'm very happy to be back and to meet my friends. So thank you very much. It's a pleasure to join this meeting. Thank you.
Yes, Dr. Jayanta Roy, your overview, and please take it forward from here.
Okay, thank you so much. Thank you, sir, for I think we missed you in the last meeting. But anyway, we are all here today. So I think we should proceed with the first case. And who will be presenting the first one? Dr. Satyan?
Dr. Rajeshwar is first in the line for the day.
Okay. So I request Dr. Rajeshwar to start his presentation, please.
Yeah. Just a moment. Sorry for delay.
Sure, sir.
A very good evening to everyone. So today I will be talking about role of TNK in acute ischemic stroke. I will briefly talk about a few studies, and then I will come to the real cases. My slides are visible?
Yes, sir, your slides are visible.
Yeah. So I think the general principles are always same, whether we are using altiplase or tenecteplase. We have to achieve timely recanalization of occluded artery and reperfusion of ischemic tissue, and then optimize the collateral and avoid secondary brain injury. Acute reperfusion, as we all know, is the most effective treatment, and at the same time, adequate hemodynamic management is the key, and we need to monitor our patient for developing brain edema, and early recognition and management of systemic complication is very important. And last but not least, the stroke unit care, that is very important, and each member contribute a lot. So we first have to look at the patient eligibility and then time the patient when he was seen well, because that is the most important question that determine how we are going to recanalize our patient. NIHS, then vital signs, checking glucose, blood pressure, and without any delay, neuroimaging, whether we are doing CT or MR, that depends on which center, because different center have their own protocol, but CT, it is easiest and it is available in most of the center. And along with CT, we also do CT angiogram and the CT perfusion to look at what is the core and penumbra. So I will not go into all the indications and contraindications. In neuroimaging, as I mentioned, that is the vital for treating these patients. So plain CT, CT angio for giving thrombolytic drugs are enough. And whenever we find a large vessel occlusion, we have to shift the patient to DSA suite for mechanical thrombectomy. So moving to relatively newer drug, that is tenecteplase. So tenecteplase is produced from native TPA using recombinant DNA, and TNK protein is modified in 3 locations, giving it favorable pharmacokinetic and pharmacological profile when it is compared with TPA. It includes 15-fold higher fibrin affinity and greater resistance to inactivation by PA inhibitor 1. So that gives it a long half-life. So coming to newer indications which were put forward by EHA and EIS. So in 2019, what has been put forward is it may be reasonable to choose tenecteplase single IV push with a dose of 0.25 milligram per kg, maximum dose of 25 milligram over intravenous alteplase in patient without contraindication for IV fibrinolysis who are also eligible to undergo mechanical thrombectomy. So this is a newer recommendation. And similarly, tenecteplase administered as a 0.4 milligram per kg single IV bolus has not been proven to be superior or inferior to alteplase, but might be considered as an alternative to alteplase in patient with minor neurological impairment and no major intracranial occlusion. So this is also a new recommendation. So about background. So the first line of fibrinolytic drug which was proved for MI in 1999, and tenecteplase superior to alteplase in extend 1A, and meta-analysis has also shown that it is not inferior, and tenecteplase is easier to administer and can facilitate treatment and transfer. The most advantage is it can be given as intravenous push in 5 seconds. So I will talk about a few studies, landmark papers. So one of the important paper which was published in 2018 in New England Journal of Medicine, where they have compared tenecteplase with alteplase before thrombectomy for ischemic stroke patient. So in this study, the total number of patients included were 202, and 100 patients were assigned to receive tenecteplase and 101 to receive alteplase. And the primary outcome occurred in 22% of patients treated with tenecteplase and 10% those treated with alteplase. And the primary outcome here was defined as reperfusion of greater than 50% of involved ischemic territory or absence of retrievable thrombus at the time of initial angiographic assessment. So what they concluded that tenecteplase resulted in better 90 days functional outcome than alteplase, that is MRS of 2 versus 3, and p-value was significant. So they concluded that tenecteplase before thrombectomy was associated with higher incidence of reperfusion and better functional outcome than alteplase among patients with ischemic stroke treated within 4.5 hours after symptom onset. So if we look at the shift analysis, tenecteplase versus alteplase, in both groups, they were matched in terms of their baseline characteristic, age, NIHS. And in terms of MRS, we found that the favorable outcome is in more patients when we look at tenecteplase group as compared to alteplase. So this is another study where tenecteplase versus alteplase for management of acute ischemic stroke, that is NOR test, a phase 3 randomized open label blinded endpoint trial. So this was published in Lancet Neurology in 2017. So in this particular study, the investigator recruited patient from 212 to 216. So the sample size is 1107, and these patients met the inclusion criteria. And in a ratio of 50 to 50, they were included in both arms, that is tenecteplase and alteplase. And the median age and NIHS and other baseline parameters, they were similar in both group. And the final diagnosis other than ischemic stroke or TIA was found in 18% of the patient in tenecteplase group and 17% patient in alteplase group. The primary outcome was achieved in 64% of the patient in tenecteplase group as compared to 63% of patient in alteplase group. And by 3 months, the 5% had died, and that number was similar in both group, and frequency of serious adverse event was also similar in both group. So they concluded that tenecteplase was not superior to alteplase and show a similar safety profile. And most patients enrolled in this study had mild stroke. So that was the interpretation of this study. And there is another study which was published in Lancet Neurology, that is comparison of tenecteplase with alteplase for early treatment of ischemic stroke in Melbourne Mobile Stroke Unit, that is TASTE, a phase 2 randomized open label trial. So what they found that treatment with tenecteplase on MSU in Melbourne resulted in superior rate of early reperfusion compared with alteplase, and no safety concerns were noted. So this trial provided evidence to support use of tenecteplase and MSU in an optimal model of stroke care. So comparing the administration practices for alteplase versus tenecteplase. So when we talk about alteplase, it is given as a bolus of 0.9 milligram, maximum 9 milligram, followed by infusion of 0.81 milligram per kg. So the total dose we take is 0.9 milligram, and after reconstitution, 10% we give as bolus, followed by infusion over 1 hour, rest of the dose. Whereas for tenecteplase, we use a dose of 0.25 milligram per kg body weight with maximum of 25 milligram. So another difference in terms of duration of administration is in alteplase, infusion continues for 1 hour, whereas in tenecteplase, it is finished over 5 seconds and cannula is flushed prior to giving the drug as well as after giving IV push. So coming to real life cases, so I will present 2 cases. One is young lady, 30 years old lady, presented with acute history of dysarthria, left upper and lower limb weakness, and 3 to 4 episodes of vomiting 2 hours prior to admission. So hemodynamically, she was stable. Her NIHS was 12. We did CT head. So there was no intracerebral hemorrhage. And in the right cerebral hemisphere, we found subtle hypodensity. When we look at the section at MCA, we found there was hyperdense MCA sign. So this is the CT angio, which is showing cutoff of middle cerebral artery. So patient was given TNK, and because it was case of large vessel occlusion, so patient was taken up for diagnostic angio and mechanical thrombectomy. So what we are seeing over here is ICA is filling, A1 is and its branches are filling, whereas M1 it is showing acute occlusion and there is no filling of M2 and M3 branches. So this patient, after giving TNK, patient was taken up for mechanical thrombectomy. So suction aspiration was done. So after that, what we are saying that all the branches, that is full M1, M2 and M3, all were filling. So this was CT scan, which was performed 24 hours after the procedure. So what we are seeing over here is there is subtle hypodensity in the basal ganglia and corona radiata. and there is no reperfusion injury demonstrated over here. And clinically, patient showed improvement. So patient was discharged 8 days after hospital stay, and her condition, she was conscious, alert, and she started moving her paralyzed limb with certain residual weakness. And 1 week after follow-up, patient was able to walk with assistance. So that was our first case. And there is another patient, young patient, 35 years old, with no obvious comorbidities. So this patient also presented with left face, arm, and leg weakness. The patient was within window period, and he was drowsy. NIHS was 15. So we did MR. So for this patient, actually onset time, family, they were not very sure, but the MR images showed there was diffusion restriction and flare did not show established changes. And we did MR angiogram, which showed M1 occlusion. So this patient, because he had large vessel occlusion, so he was taken up for DSA. So this is right ICA shoot. What we are seeing over here is that ACA territory and part of basal ganglia, and that is filling. However, there is no filling of M2, superior inferior division and their branches. This patient was also taken up for mechanical thrombectomy after giving TPA. So this patient also received intraarterial TNK, 4 milligram was given. Here we can see microcatheter in the middle cerebral artery. So this is tip of microcatheter. So suction and intraarterial tenecteplase was given. So this is the end result. So this patient also had TK3 recanalization. However, his, like previous patient where most of the tissue was salvaged in the right cerebral hemisphere. So this patient, in spite of having TK3 recanalization, he had hypodensity in right cerebral hemisphere, though anterior cerebral artery, part of anterior frontal and posterior part was spared. So his MRS at follow-up was 3. So I will stop it here. So these are the 2 cases I want to show who were treated with intravenous and intraarterial TNK.
Thank you, Dr. Rajeshwar. Is there any question waiting at the chat box?
I'll just check, sir.
Please.
So no questions as such, just a few comments on the presentation, and that's all.
Okay. So can you see them?
So the comments are like, good presentation, very knowledgeable workshop, those kind of comments, but no questions as such.
All right. So, Mr. Sir, is there any comment from your side?
Hi, good evening, everyone.
Yeah, Dr. Saxena.
Yeah, I am Dr. Sanjay Saxena. Sorry for being a little late today, but I heard the presentation. It was very crisp and very nice. So in second case, did you do some perfusion study also? It was just diffusion flare mismatch.
Sir, we did only diffusion and perfusion mismatch with DW and flare mismatch because it was already getting late and the area involved was quite significant. So that's why we didn't do, CTP. We took 2 angiogram suit.
So I think she did well. She had reasonably good outcome, and probably we were close to 4.5 hours or maybe beyond that. And with extend trial, there may have been some benefit of tenecteplase in that situation, but it is still debatable and too early to talk about. There are some centers which are using that software for perfusion imaging, which can give results very quickly, though it is very expensive. But
Sir, we have Rapid with us, but
so did you use it?
yes, sir, we are using it. But
Okay.
somehow I couldn't get the images, so I haven't posted.
Can you share your experience with that? Because we are looking forward to procure
Okay.
same software.
I will say it is good, but again, it won't replace your own judgment, because sometimes you have to compare with both your own image interpretation and Rapid. Sometimes it can overestimate also. That also we have seen. But by and large, it gives a decent picture.
Does it add on to the cost burden to the patient?
See, for us, actually, the company, we got sponsorship for 1 year.
Okay.
And so this is how we managed.
So you are not passing it on to the patient. That's
No, we are not passing. Actually, in our CT machine, also there is a perfusion map. We have to place tracker over the artery and vein, and it will calculate map and give you all the timings.
Yes, it can study even a CT perfusion. I think this is what I presume. That's what Rapid can interpret even a CT perfusion study quickly, but as your experience says, it may not be too very reliable to
Yes.
go without interpretation.
Can I just comment? Well, we also do have Rapid AI. We use that. And I agree with Dr. Rajeshwar. It's useful, definitely. But first of all, the image acquisition should be very accurate, because the bolus tracking in CT angio is very important, especially when you are doing a multi-phase CT. So here, there may be some problem if we do not inject the dye or take the images at the right phase. Mm-hmm. So that is important. So sending the right image after proper acquisition is important to get a quick interpretation. But yes, if you do a good quality CT angio without much movement, then the reformat and diagnosis of LVO is pretty quick. So it's very useful for people who are not very conversant with quickly looking at the source image and finding the LVO. So for the residents or the other people, it's really helpful for the LVO thing. Perfusion, yes, it can map, but you still need oversight.
Yes.
You still need it for the perfusion thing. And for aspects, I'm not very impressed with the aspects. I asked these Rapid AI people a couple of times because they made gross mistake in aspects. So ask them, how could you make this mistake? They could not give me any satisfactory answer. So other than LVO and some perfusion interpretations, I think Rapid is not very useful, but at times, yes.
Maybe beyond 4.5 hours, it may be utilized in a better way.
Yes, yes. Especially with LVO and perfusion mismatch. Right.
And sir, you have brought a very important point, like acquisition. It is very important aspect, because sometimes middle of the night when senior technician is not there, correct, and what time they are injecting the contrast, and most of the stroke patients, some of them are obese. There is a lot of motion, and putting proper cannula. All these things contribute to proper images.
Very much, very much.
Great. Okay. So I think we will keep on discussing, and we can move on with our
go to the next one, right? Dr. Santhan, please.
Warm good evening, everyone. I'm Dr. Satyan. I'll be presenting a case which I perceived was a high-risk acute ischemic stroke, and which was taken for thrombolysis. I will just present my flow of thought for such a patient, and would love the inputs of the moderators and senior consultants as to how we could have refined it in any other way. So he's a 51-year-old male. He's a known case of dilated cardiomyopathy with low ejection fraction of 20%. He was admitted to a hospital recently for fracture of right tibia, and he was operated by open reduction and internal fixation. 6 days subsequent to the surgery, he had an acute onset drowsiness with weakness of all 4 limbs and drooping of both eyelids at 3 a.m. Basically, the patient had retired to bed and had woken up at 2 a.m., from which he was not able to retire back to sleep. And at the time of onset of ictus, patient was awake and was able to tell his history by himself. Probably in an HTU setting, he was not able to get a good sound sleep, and he was well awake into the night, and thus was able to pick up his symptoms very well. The patient was clinically examined, and the findings were observed by resident on call. I'll just play a few videos of his examination at the time of onset of the ictus.
हाँ पूरा नाम बोलिए पुनीश सुरेश ठीक है भाई.
So as we can appreciate, there is bilateral ptosis. He's not able to open the eyes, and he had to be aroused also. That part of the video is missing, and there was clear-cut slurring of speech.
ये हाथ ऊपर उठाइए, ये हाथ ऊपर उठाइए, ये वाला, वो वाला हाथ ऊपर उठाइए, ये वाला उठाइए, उठाइए इसको हाथ को भैया, ये वाला हाथ ऊपर उठाइए, नहीं उठ रहा.
So as is evident from the video, he was not able to lift his left upper limb totally, and right upper limb was also weak.
हाँ पूरा नाम बोलिए पुनीश सुरेश ठीक है भैया. ये हाथ ऊपर उठाइए, ये हाथ ऊपर उठाइए, ये वाला, वो वाला.
Sorry, the video played again. Yeah, this is the second part of the video.
पैर मोड़िए, पैर मोड़िए भैया, पैर मोड़िए, पैर मोड़िए.
So there was weakness of both lower limbs, and that was also severe in terms of grading, and he was barely able to move both the lower limbs in the bed. So we had a suspicion of, because of the abrupt onset of the neurological symptoms, diagnosis of ischemic stroke was considered, though there were a few odd points, patient having bilateral upper and lower limb weakness, asymmetric although, along with dysarthria and ptosis. So the thought process was that it was going towards a posterior circulation territory. Thus, in our setting, we for patients in whom we consider posterior circulation stroke, we opt for an MRI at the outset only, and that was what was advised for. And this is the MRI brain pictures which were available. I'll just use my pointer. So there was a small, very subtle infarct in the left cerebellar hemisphere. Then there was a definite area of diffusion hyperintensity involving the bilateral midbrain territory and bilateral thalamic territory. It was asymmetric. It was involving the right side more prominently as compared to the left side, and that probably explained his weakness also. The weakness of left side was much more marked as compared to the right side. And there was subtle flare positivity, which was also evident on the flare imaging with respect to the thalamic hyperintensity. As we can appreciate from this fourth image, there was subtle flare positivity, which was quite evident. And we got an MRI angio or TOF also, time of flight imaging, and that showed that the posterior circulation vertebrals were well visualized, and the basilar was well visualized. The PCA, the initial segment, was visualized on the right side, and left side was a bit hypoplastic. But there was no overt evidence of any occlusion, major vessel occlusion, or major vessel stenosis. Anterior circulation looked unremarkable. So clinical radiologically thinking, initially, if we had to discuss only on clinical aspect, the differentials we had kept was either an arterioperturon infarction, and considering the thalamic involvement and the midbrain involvement. Because of the involvement of the left cerebellar hemisphere, I was also inclined towards thinking on top of basilar artery infarction or a basilar artery thrombus which had propagated towards arterioperturon. There was a rarer possibility of deep cortical venous thrombosis also, which was considered, but that looked unlikely given the present setting and the characteristic MRI picture. And the neoplasm was only for academic consideration. So the main differential was an arterioperturon infarction or a top of basilar artery infarction. So now the possibility was, now the consideration was whether to go ahead with thrombolysis for this patient because he was in window period. His time of onset was at 3 a.m. and he was very upright and quite sure about it. The call was received at 4 a.m. and the patient was considered for IV thrombolysis, but even at that time, there were a few hindrances in my own mind as to whether I should be going ahead with IV thrombolysis for this patient or no. What were those hindrances? It was that the patient had a recent major surgery. It was only 6 days old and it was involving a major bone of the lower limb, that is a tibia. So he could have bled from that side because of the bleeding complications, which are well known with IV tenecteplase or alteplase. And the other thing of concern to me was that the patient had received prophylactic dose of low molecular weight heparin in the past 24 hours. He had received that dose at 10 p.m. the previous night for DVT prophylaxis and uniform immobilization of right lower limb. Perfectly justified and perfectly well within their rights to be giving that dose of low molecular weight heparin. But that was weighing at the back of my mind that in the presence of a major surgery, and the fracture of tibia, along with the patient having received an anticoagulant, whether I should be considering IV thrombolysis or no. The third issue was the subtle flare positivity, which was weighing on my mind, but not to that great an extent because I knew that the time of onset was quite sure. So I was well within my rights to proceed for IV thrombolysis, irrespective of the flare positivity. So we'll just discuss these caveats one by one. What about the recent major surgery? As previous speaker, Dr. Rajeshwar, has also spoken about the guidelines, updated guidelines of American Heart Association and in 2019. Even in that also, it is mentioned that use of IV alteplase in carefully selected patients who present with acute ischemic stroke and have undergone a major surgery in the preceding 14 days may be considered, but the potential increased risk of surgical site hemorrhage should be weighed against the anticipated benefits of reduced stroke-related neurological deficits. So this doesn't lead us to more clarity, lead us to any clarity, in fact. So if we are to go to the European guidelines, the ESO guidelines were published in December 2020, and their take on recent trauma surgery was, which appealed to me more, that if the major surgery is on a non-compressible site where the bleeding is likely to lead to significant hemorrhage, for example, the abdomen, chest, or skull, or well-vascularized tissues or large artery, then they recommend no IV thrombolysis. That is the only caveat which they consider for no IV thrombolysis. Irrespective of that, other surgeries, we are within our rights to go for IV thrombolysis. My patient had open reduction internal fixation of tibia, which I do assume is an easily compressible site. And if any bleeding is to occur from that side, it can be compressed. So the next caveat was the dose of low molecular weight heparin. This was the strongest consideration which was holding me back. And with regards to this, we have evolved the guidelines, and there's a reason why these guidelines evolved from 2015 to 2019. One of these points has been discussed in the 2019 guidelines. It states that IV alteplase should not be administered to patients who have received a treatment dose of low molecular weight heparin within the previous 24 hours. Now, we all know treatment dose is different and prophylactic dose is different. What my patient was on was a prophylactic dose of low molecular weight heparin. So this caveat was also done away with, and we could go ahead with thrombolysis of this patient. And this recommendation refers to full treatment doses and not prophylactic doses. The INSET itself clarifies the point. In 2015, they had recommended that IV alteplase should not be given to patients who have received a dose of low molecular weight heparin within the previous 24 hours. But this has been updated, and this is how we grow, and this is how we become wiser with each guideline. Now, with respect to diffusion flare mismatch, how big of a caveat was that? So this is a table which was taken from an article published by the group from Japan in Journal of Neurological Sciences 2010. They had shown that it's not a dictum that any patient who comes within window period between 4.5 hours, he has to have a flare diffusion flare mismatch, to be correct. Even in cases as early as 1.5 hours after the onset of icters, 5% of patients can be flare positive. And this number increases to approximately 30% by the time of the window period, that is 4.5 hours. So roughly 1/3 of our patients can have flare positivity, and that should not be a deterrent in our decision making. We should be sticking to the clinical onset of ictus, and 4.5 hours should be the cutoff for the clinical onset of ictus. If the patient is within 4.5 hours of ictus and we have a patient who's a suitable candidate for IV thrombolysis, I think we should go ahead with that. So the next thing to choose was once we've taken the decision that we have to go ahead with IV thrombolysis, the choice of thrombolytic was also an issue, but whether to go with alteplase or tenecteplase. So as is shown in this figure, the rates of spontaneous intracranial hemorrhage are lesser with tenecteplase. And that is the sole reason for opting for tenecteplase in such a high, in this high-risk patient, what I perceive to be high-risk thrombolysis. I would be more confident if I had a molecule which would be less prone to cause symptomatic ICH or bleeding from the operated site also. Thus, I opted for tenecteplase, and with routine IV thrombolysis, we counsel the patient that there is a 6 to 8% risk of IC bleed. And because of these caveats, the caregivers were sensitized that there is a higher than normal risk of bleeding, and consent was sought for proceeding with thrombolysis. There was a slight delay in deliberation, even from my side. Even I was reading up a bit, and finally the patient was thrombolized at 6 a.m. That is 3 hours after the onset of ictus. And he was thrombolized with tenecteplase 0.25 mg per kg, which was given as a bolus dose over 5 seconds actually. And by the end of 2 hours, he had an improvement in his stroke scale scores, and by the time of discharge, had recovered a major part of his deficit. The persistent deficit was ptosis bilaterally and mild left upper limb weakness. So this is his
इधर देखिए मेरे को देखिए, इधर देखिए, आँख इधर देखिए, इधर देखिए, ऊपर देखिए, ऊपर 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 नीचे, ठीक है, जबान दिखाइए, जबान दिखाइए, ठीक है, दूसरा हाथ दूसरा हाथ वो उठाइए, दूसरा हाथ उठाइए, उठाइए अंकल, दूसरा हाथ उठाइए, वो दूसरा वाला, दूसरा हाथ उठाइए, इसको इस हाथ को उठाइए, इधर देखिए.
So this was a post-thrombolysis CT. It showed the thalamic infarction and the midbrain infarction was also there, but there was no hemorrhage. There was no symptomatic ICH. This was basically CT angio which was done, and that's why the contrast was evident on this one. The same source image was used for assessing whether the patient had an ICH or not. And with this, I'll just brief up about arteriopercheron in a few slides, and then I'll wind up. Basically, as we know from pathology, from understanding of anatomy, arteriopercheron arises as a single unpaired trunk from either of the PCAs, and it supplies bilateral paramedian thalamus and the rostral midbrain. This is a normal thalamic and midbrain perforators, and this is the arteriopercheron, which arises in this case from the right PCA and is supplying both the bilateral thalamus and the rostral midbrain. So patterns of AOP infarction are bilateral paramedian thalamic with midbrain. That is the commonest one, 43%. If the midbrain is not there, it's 38%. And bilateral paramedian thalamic with anterior thalamus and midbrain is 14%. And rarest of all is bilateral paramedian thalamic with anterior thalamus without midbrain. So this is an example of arteriopercheron infarction, which was published in the journal, American Journal of Neuroradiology. And this case was similar to our case by virtue of its bilateral thalamic and asymmetric thalamic involvement, right more than left, and involvement of the midbrain also. And this is another case of arteriopercheron infarction. The authors wanted to discuss the V sign in this V sign along the pile surface of midbrain interpeduncular fossa, representing the V sign, which they consider is pathognomic of arteriopercheron infarction. The other pattern is only of bilateral thalamic involvement with midbrain being spared, and there's an infarction in the PCA territory also, which is an old one. And so the final points from my side is that we have to stay updated. The guidelines have changed from 2015 to 2019 and 2018, and contraindication with respect to prior administration of low molecular weight heparin was restricted now only to the therapeutic dose rather than prophylactic dose. And we need to be thorough with regards to a review of a particular topic, and contraindication can be an absolute or relative, and we have to weigh the pros and cons of the procedure we are about to perform, and the attendants definitely need to be taken into confidence prior to attempting anything controversial. So guidelines are there to help us, and we can take our own individual decision making capability also. Basically what I learned from this case was that no patient comes to us after reading a textbook. It is what we there can be multiple contraindications, there can be multiple relative contraindications. The final decision making has to lie with us, and we should trust our guild practitioner and take the best possible therapeutic decision. So I'll just wind up with this saying from Sir Gowers that no practitioner can do his daily work with any competence without constantly observing for himself and constantly reasoning from his own observations. The work of the medical practitioner, high or low, is personal science, as that of no other work there is. Thank you.
So I think it was a very bold, and we must compliment you for considering this patient for thrombolysis. And it was really a very, very great effort, bold effort, and an eye opener for many of the practicing neurologists. And these were obviously relative contraindications, no doubt, but at the middle of the night. So you need extra kind of appreciation for that. And I must congratulate you for doing an excellent work and your dedication. That's just is how we should be for any stroke patient without wasting any time. So I think that was very nice case, and very well discussed and very well studied before you actually thrombolized. What could have been the etiology? Was it the hypoperfusion, or he had that dilated cardiomyopathy? So a little point of concern here would have been to rule out an thrombus in the left ventricle in this situation. And that could have been, I mean, you should have done it, I am sure. But that was, you had got some time to do even a little short echo at that time to rule out any thrombus in the ventricle before you went for IV thrombolysis. That is a routine, not a routine, but in specifically these situation, high risk cardiac cases, we actually could have done it. But it was midnight, I know. There wouldn't have been anybody to do a echocardiography at 3 a.m. or 4 a.m. So I must compliment you. And really good, great learning, and you must publish this in a relevant journal or the literature, so that people can share your experience. Compliments to you. Well done.
Thank you. Thank you.
Yeah, I fully agree with Dr. Saxena about his comments. And your last couple of slides actually summarizes the whole thing. I mean, yes, guidelines are there, but your judgment and your decision making is individual. And despite the medical legal issues are there, so long you are very clear in your reasoning, solid clinical reasoning, as you very nicely mentioned and worked up the case. I think that is the most important learning point from this case, because guidelines are there, but because relative contraindications there are many. And as you mentioned, this patient got benefited, and definitely we had a good outcome. So I think applying a guideline like it's not a sacrosanct. There are many areas where we can play around it, so long your reasoning is solid, your clinical thinking is rational. And one thing is there, that to break the rule, you have to know the rule. So know the rule properly, then you break the rule. But for the young consultants, I always tell them, first initial 4 or 5 thrombolysis, be a little copybook, because my supervisor used to tell me, you have to survive your first bleed. Once you survive your first bleed, then probably you get more confident. So yes, initially be careful, but more you learn with time, your experience, you know where you have to go a little beyond the line, but with good reasoning. Great case. Thank you.
Thank you. Thank you.
So now the burden of stroke is increasing, and every day you encounter in a month maybe 20 to 30 patients who are eligible or maybe closely eligible to IV or intervention for acute stroke. So there would be more chances of learning here, and at the same time committing something off the record also. So we must not forget about the basics of thrombolysis. And some time back, it so happened that we thrombolized a functional patient, but it can happen. Nothing was harmed and it was well within the window, and probably so that is what keeps on happening. If we all share our experience, we would have had many experiences, many learning in our situation, especially a very difficult situation. If you have a very small infarct in a LVO and your mismatch is not seen, there is no penumbra, so and the patient is there within 6 hours, so do you proceed with thrombectomy? Or is there a way, or now you are adopting any technology to study the thrombus morphology, the clot burden and the size and the location? Are we considering that into before we proceed for mechanical thrombectomy? Or if we have good collaterals, in that case, do we still consider thrombectomy? What is your experience?
Well, I think that's a very difficult situation sometimes, because in one hand, you have a very non-disabling stroke, maybe a very low NIH, and disability is very minimal. So in that case, we usually do not proceed with any interventions, be it IV, be it mechanical. But at the same time, there is a LVO sitting. So I think more information regarding the collaterals are important. If you ask me, if you have a very good collateral, definitely the patient must be having a good collateral to hold that area. Otherwise, there should be more deficit. So if the patient has got a good collateral and very minimal deficit, then probably I will, and beyond IV window, then probably I will watch the patient closely for 24 hours, because the patient might have a stroke or worsening beyond 6 hours even. So they can be still eligible for late window interventions. So those patients are actually little tricky. I mean, you are on the nerves all the time for next 24 hours or so. So I watch them. The moment they deteriorate, even by 2 NIH, I think it is enough warning the collaterals are going to fail. Then I do not wait and I go ahead and do it. I mean, otherwise, many patients, I can recall 2 patients at least who really did well despite this, and there was no worsening further. So, but it depends on your good day or bad day.
True. So it's still, we need to learn a little more about the perfusion, little more.
That's right.
And even if there's a small infarct and there is a mismatch, obviously you would proceed with the procedure. That is what I think we practice. But obviously there are a few experiences which we have also had. We have had a worsening after 12 hours. Yes. And somehow patient was given anticoagulants just to buy some time. I don't think that's a recommendation to do that, but it was given and the patient had a bad outcome. And few patients, they did reasonably well, but yes, close monitoring is always a clue to that. And maybe some studies with transcranial Doppler in certain, these modalities can be used to have a objective as well as subjective follow-up of observation of such patients.
That's right.
So any
comments?
Very nice.
Yes. Mr. Sir, any comments, sir?
Very interesting cases, but what is important is that these guidelines, if you see the trials, initially the exclusion and inclusion criteria are so stringent that if you see the initial trials, all these confounding variables would have been excluded. I mean, the patient would not be included. And later on, as we mature, then we start evaluating overall patient. There were so many confounding variables in this patient, and each of them, if you did not want to, if you decided not to thrombolize, you would have taken. He's undergone surgery, he's gone heparin, and he's got so many other comorbidities. But then, overall, we have to assess the overall patient and take a decision. These guidelines are used to guide us for a better outcome, and they are not a rule. We can always, considering our experience, considering the knowledge, and considering the changing guidelines, we can always take in, rule in or rule out our patients. So I think it's very, very good patient. The latter patient was very interesting, and the presenter discussed his dilemmas and the way difficulties he had, and then ultimately ended up with a good outcome. Sometimes we may be in trouble after doing all this. Sometimes once in a while we all have burned our fingers and then we repented, and that is what is experienced. So I'm very happy to be witnessing these cases, and thank you very much.
Thank you, sir. So, is there any question from the audience?
Sir, there are only comments. There are no questions as such. But yes, there are a lot of comments on the fabulous presentations made by the two speakers. Yes.
Okay, excellent.
So I would like to have one suggestion. Like this case had a good outcome, but even if we didn't have a good outcome, we should share. That is another one of ways to share our experiences. We cannot have an ideal outcome every time. We should learn from our problems or situations. So we should share one good outcome case and one with we didn't have the expected outcome. So
that's right.
That would make it a little more interesting and more learning would be there.
Good idea to share complications, but there is a publication bias and presentation bias. Usually, if you send a complicated patient to a journal, they generally would not publish it. I mean, they will find flaws in your analysis, and they will find this is why you did wrong and this is why you did not do wrong. So I agree. We learn from complications, we learn from mistakes. But unfortunately, the editors are not very kind for mistakes, and the reviewers are still more difficult. But yes, in informal sessions, we can always discuss our mistakes. But it's very, very personal. We all are human beings, and we would like to share the good part and the successes rather than failures. But yes, failures are actual teachers. Whatever you learn is from mistakes, not from not doing mistakes. So that's, I agree with Dr. Saxena.
Right.
Thank you, sir.
So I think, Dr. Saxena, any other comments?
No, I think we had a very nice discussion of very high standards. So I am participating for the first time, but I also learned a lot. Maybe same is true for many of us. Thank you so much.
Thank you. So I think we can probably call it today, and we'll reassemble maybe sometime next month.
Yes, sir. I think, sir, we had a perfect Saturday evening with around 140 plus doctors joining us live for this program today. And I would really want to thank the two speakers for coming on board, Dr. Satyan and Dr. Rajeshwar, and sharing their cases today evening and making this event a possibility. Thank you so much, sir. I would also like to thank Dr. Sanjay Saxena for taking time out on a Saturday evening and sharing his inputs and his experience with us. And last but not the least, thank you so much, Dr. Jayanta Roy and Dr. UK Mishra, for being a constant support and guiding us with this particular initiative. And lastly, a big thank you to all the audience who have joined us live. And we will be back again next month with another interesting episode of No Thrombosis workshop in AIS. Till then, thank you so much and good night. Thank you so much, everyone.
Thank you all.
Bye-bye.
Bye.
Good night.
Good night.